Well, good afternoon, and I want to thank you all for this wonderful invitation, this opportunity to describe some of the work that's been going on with regard to thyroid eye disease or thyroid-associated ophthalmopathy, whatever you want to call it. It remains a vexing problem. And here are my disclosures. The work has been funded for 37 years continuously by the NIH and some by the VA Medical Center. So the learning objectives this afternoon, I want to provide you with a brief overview of TED, the role of endocrinologists in managing the disease, and current and evolving therapeutic landscape for the disease. I want to introduce you to what may be a new concept for you, that is that bone marrow-derived fibrocytes, which are a monocyte precursor cell, uniquely infiltrate the orbit in TED and express extremely high levels of the IGF-1 receptor complexed to the TSH receptor. And to propose to you that the IGF-1 receptor, in addition to the TSH receptor, is pathogenic in Graves' disease as an antigen, and can be successfully targeted therapeutically. So when I was a young guy, seems like centuries ago, the thing that intrigued me when Les de Groot first introduced Graves' disease to me in Chicago was, why in the world would a thyroid disease skip around in terms of its clinical manifestations, sparing, at least apparently, tissues other than the thyroid, the orbit and upper face, and the pretibial tissues, a process we call pretibial myxedema. I'm glad we already had lunch. Now, what is the epidemiology of TED? Well, it's probably changing for a variety of reasons, but we talk about Graves' disease of the thyroid occurring in about 20 to 50% of per 100,000 U.S. population. Peak incidence of Graves' disease between 30 and 50 years of age. TED, on the other hand, the incidence is 1 per 19,000, at least in Olmsted County. Peak TED incidence is probably bimodal, but 40 to 60 years of age is fair. Remarkable female preponderance, 8 to 1 compared to their male counterparts, but we see the most consequential TED in older men, especially those who have used tobacco in their lifetimes. Additional potentially modifiable risk factors include, besides tobacco use, treating patients with thyroid overactivity with radioactive iodine. So in 1945, Frank Rundle described, based on all of 3 patients, the natural course of TED, where for 2 or 3 years they developed a disease with increasing severity, and progression. And we call that the active phase. And then this invariably culminates in lifelong stable phase, which, for my way of thinking, means that things stop changing. In other words, the roulette wheel in terms of whether or not a given patient is going to be left with severe disease remains unchecked, but things don't change. And many of these, at least superficial clinical markers of disease activity, including edema and inflammation, typically subside. Now, historically, we believed that any medical intervention, which fundamentally comprised the use of glucocorticoid steroids or external beam radiation, were effective only during the active phase, a so-called therapeutic window of opportunity, and that our surgical colleagues would then take the reins of management once the patient had reached the stable phase. And should the patient require, they would then be handled with a patterned, phased set of surgical procedures, starting with orbital decompressive surgery, followed by strabismus surgery if there was malalignment of the two globes, and then finally eyelid repair to restore both the cosmetic result of the disease as well as to restore appropriate draping so that the anterior surface of the eye remained well hydrated and protected from light and foreign bodies. So, as most of you know, the hallmark of TED, that is the thing that sets it apart from most, but not all, other ocular and periocular processes, is the phenomenon of proptosis, or eye bulging. And this can, in and of itself, lead to double vision, problematic closure of the eye, leading to degradation of the anterior surface, ulcerations. If asymptomatic, or asymmetric, should I say, one has a heightened concern for another process driving the trolley, and orbital cancers are at the top of our concern list. And then should the volume of the orbital contents reach a certain threshold, which is idiosyncratic, then the optic nerve becomes affected by compression and crowding, especially at the apex of the orbit, and can lead to decreased vision. So, at its heart, Graves' disease and TED represent associated autoimmune processes, and if one is to drill down to the fundamental basis for Graves' disease, one will find the loss of immune tolerance to one or more proteins, carbohydrates, or lipids. In the case of Graves' disease, the thyrotropin receptor has for many decades been the leading candidate as both being disease-specific and consequential in terms of the alterations in thyroid function that we frequently associate with Graves' disease. So, as we all know, about 10% of our patients present with euthyroid laboratory values. Their systemic symptoms and signs do not suggest any alteration in thyroid function, and another 10-12% of these patients actually present with hypothyroidism caused by blocking anti-TSH receptor. So, as I just said, both the upper face and the orbit are affected in this process, which involves the remodeling of the connective tissue, including the adipose tissue within the orbit and the surrounds. The IGF-1 receptor has only relatively recently been implicated in the pathogenesis of Graves' disease and TED, and to our surprise has opened up the gates for development of therapeutics which appear to be pretty specific for the disease. So one of the important features of Graves' disease and TED is that it's not just an autoantibody problem. It's also a problem of T-cell education, so that autoreactive T cells escape the scrutiny of the thymus and are released into the periphery, where they are up to no good. So, with regard to the common pathway at the bottom of the process that is closest to the clinical manifestations, lay the orbital fibroblasts, which importantly turn out not to be monolithic, as many of our colleagues pretend that they are. And these fibroblasts are activated through multiple channels, not literally channels, but mechanisms, including the generation of a myriad of cytokines, growth factors, as well as IgGs specific for the IGF-1 receptor and the TSH receptor. So this new concept that I wish to anoint you with is that cells we call fondly CD34 fibrocytes. These are monocyte progenitor cells, come from the bone marrow, lose many of the monocyte-specific markers, including, but not exclusively, CD14 and CD16. On the other hand, they retain CD34 and CD45. So they're a subset of myeloid cells. And what they do, through a very cute mechanism involving a specific cell trafficking to the diseased orbit, is that they respond to a chemokine called CXCL12, the cognate receptor of which is CXCR4, and is proudly displayed by these cells as they depart the bone marrow space and find their way into the orbit. Once in the orbit, they sidle up, I would say an unfortunate romantic entanglement with CD34 negative fibroblasts, which are garden variety fibroblasts like all of you in the room, unless you're thinking about developing Graves' disease. And there are a set of interactions which turn out to be consequential. That is, they are determinative of whether or not a given patient with Graves' disease decides to develop TED, and if so, how robust and reckless the disease turns out to be. So if one looks at specific immunofluorescent staining of, positive immunostaining for CD34 positive cells in the TED orbit in situ compared to no such signal found in healthy orbital tissues. Now, one of our earliest unfortunate findings from a political perspective, that is, was that these fibrocytes actually pretend like they're thymic epithelial cells / thyroid epithelial cells. And what I'm saying is that they express every thyroid autoantigen that's associated with thyroid disease, including those that are preferentially expressed in Hashimoto's and or Graves' disease. So they express fully functional thyroglobulin. They can organify iodide. They express high levels of TSH receptor, levels that rival what we find on thyroid epithelial cells. They express functional sodium iodide symporter, and they express TPO. They also, as it turns out, express a non-canonical transcription factor known as AIR, or autoimmune regulator protein. So what's significant about the expression of AIR is that this protein was supposed to only be expressed within the thymus. And the way in which autoreactive T cells are selectively depleted under normal thymic education is to express all of the self-antigens, potential self-antigens, and once they glom on to these proteins driven by AIR protein, they are eliminated. But in autoimmune diseases, for some reason, the thymus is asleep at the switch. And so what we did was we knocked out AIR genetically, and the expression of all of these promiscuous proteins that make these cells resemble cells of the thyroid is that all that expression went away. So instead of TTF and PAX8 and our usual suspects within thyroid epithelial cells driving thyroid-specific proteins, it's AIR. You've heard that to err is human. Maybe that's why Graves' disease doesn't occur outside of human beings. So anyway, one of the next things we did was to compare the levels of all of these proteins and many more in fibrocytes that we collect from the peripheral circulation versus those that come from surgical explants from patients undergoing decompressive surgery for their TED. And when we looked at the levels of the respective proteins and the respective mRNAs, we found that the levels in the circulating fibrocytes were vastly higher than those of their orbital fibroblast counterparts. And so, believe it or not, I used to have a full head of hair, and it used to be quite dark, and now you can see I'm follicularly impoverished. But I would say that process was accelerated in trying to identify exactly what was going on, this interaction between the 34 positive fibroblasts and the 34 negative fibroblasts. And finally, we identified the culprit as a glycoprotein called SLT2. And I don't know how many of you in the audience are neurobiology devotees, but SLT2 at that point had only been associated with CNS development, where what it does is to impose respect for midline integrity, so that inappropriate decussation of neural axons doesn't occur in specific portions of the developing CNS. So anyway, we found that this molecule is expressed at high levels by CD34 fibroblasts. It's heavily glycosylated, and it binds to its cognate receptor known as roundabout 1 or ROBO1. And the way it works is through the beta-catenin pathway, where it downregulates beta-catenin and has an impact on cyclin D1 and a cadre of other important regulators of DNA replication. So here's the magical mystery tour as it relates to how we put together SLT2, ROBO1, CD34 negative fibroblasts in the pathogenesis of TED. So if the CD34 negative cells and their obligatory SLT2 production dominate the orbit of a patient with Graves' disease, they don't develop TED, or it's clinically undetectable or unimportant. On the other hand, if there is a numerical embarrassment with too many CD34 positive cells in the orbit, then the SLT2 ROBO1 pathway is overwhelmed and patients develop severe TED. So let's switch gears now to discussions about the IGF-1 receptor as a therapeutic target for TED. So we know that steroids and alternatives, some of the NSAIDs and similar anti-inflammatories, are poor options in TED for a number of reasons. We were proposing that the TSH receptor had a so-called partner in crime. At the time, this is 20 some odd years ago, many cell biologists were first discovering the importance of the IGF-1 receptor and its first cousins, EGF receptor, fibroblast growth factor, platelet-derived growth factor, etc. Well, we decided to get on the bandwagon. And through a number of hints, I would say, clues, we started drilling down on the IGF-1 receptor and its potential as explaining, at least partially, the pathogenesis of the disease. And at the time, you can imagine our good, trusting friends at the ATA were more than excited to embrace new concepts about Graves' disease, welcoming these concepts with open arms, and some of the suspect study sections really didn't exactly welcome me until I cleaned up my act and resubmitted proposing to perform safe science, which did not include in centrality the IGF-1 receptor. And what they were very upset about, and looking back, I understand their dismay, was that in fact I was proposing that a G protein coupled receptor like TSHR and a tyrosine kinase receptor might have anything to do with each other, which at the time was balderdash. And we persisted, and we started examining not only the levels of IGF-1 receptor, but also both the canonical and non-canonical signaling pathways, including those that might be shared between GPCRs and RTKs. So we found that the levels of IGF-1R displayed on orbital fibroblasts from patients with TED were considerably higher than fibroblasts from healthy individuals. And then we went further and actually showed that T cells and B cells and NK cells and monocytes all overexpressed the IGF-1 receptor. And we thought this was, pretty cool. Didn't know what it really meant, but it got the renewals off of our back for another 5 years when we continued to play. And then we devised an experiment where we radio-labeled IGF-1 and demonstrated that IgGs from patients with Graves' disease could displace this radio-labeled IGF-1 from its receptor on orbital fibroblasts. It wasn't as potent as unlabeled IGF-1, but it was pretty potent. And similarly, we showed that DES13, which is absolutely specific in its binding avidity for the IGF-1 receptor, had within a half a log order the KD or the KI of our IgGs from patients. We then subjected individual cells and orbital tissue from patients with Graves' disease using confocal microscopy and showed that the two proteins were within a couple of angstroms of each other. We resorted to what we call pull-down experiments, where we could bring out of solution one of the receptors with a monoclonal antibody directed at the other receptor. So this strongly suggested that not only were the two receptors in close proximity, but they also formed some sort of a physical association. We never characterized further the nature of that interaction, though we've looked at a whole host of mutant receptors trying to isolate that the actual amino acids involved in this physical crosstalk. And then really the thing that sold us on this whole nonsense of therapeutically targeting the IGF-1 receptor was to subject orbital fibroblasts or thyroid epithelial cells, as I show here, with IgGs from the same patient, and then to assess the activation of one of the downstream signaling cascades common to the TSH receptor and the IGF-1 receptor. And in this case, we looked at ERK1/2, and what we show here is that, yes, IGF-1 activates the phosphorylation of ERK, and that a monoclonal, which is the only one we had access to, known as 187, could block that activation. We did the same thing with recombinant human TSH and showed that, in fact, 187 could block the activation. And then we took the IgGs from patients and showed the identical blockade with this 187 monoclonal anti-IGF-1 receptor antibody. So thinking this is two shots on goal, in other words, it was really not going to matter terribly much whether the autoantibodies in play were anti-TSHR or anti-IGF-1R antibodies. We should be blocking both of them. So with that in hand, we started a many-year quest looking for $30 million to create our own human or humanized monoclonal against the IGF-1 receptor. The recession meltdown of 2007, 2008, 2009. Meanwhile, I'm being recruited from UCLA to Michigan, and I'm ready to throw the work into the dustbin when I get a call one Friday afternoon in Ann Arbor from a guy called Guido. And Guido has a very heavy Italian accent, and he says he's calling from Basel, Switzerland, and he's retiring as the global head of R&D of Roche. He has an opportunity to license what became teprotumumab. Would I be interested in collaborating with his new developmental company in bringing forward work that would culminate in clinical trials? And having struck out with the investment bankers in Palo Alto, I said, sure, what do I have to lose? And so that's what happened, and the rest of the story we'll get to in a minute. But so this is scripted from a dream of mine, where CD34 positive fibroblasts, and one could substitute CD34 circulating fibrocytes, are really at the center of this cellular cabal, where these cells communicate. They exchange a molecular handshake with T cells, and indirectly with B cells. They can differentiate into mature adipocytes and myofibroblasts. In other words, in our dream, they seem to fulfill many a priori expectations for a smoking gun in this disease. So quickly to mention that most cases, especially those with what we call mild TED, we handle at Michigan in pretty conservative way. We don't typically treat these patients with steroids unless they're quite symptomatic. We refer them to ophthalmology, though I pretend on being an ophthalmologist sometimes, since I'm surrounded by 7 oculoplastic surgeons on faculty and numerous house staff. But the main message here is to do an assiduous baseline evaluation of the eye and the orbit, and to implement protective measures, have patients wear granny wraparound sunglasses, avoid wind and desiccating sunlight. I use a lot of over-the-counter eye drops, rarely steroid eye drops, and we make sure that we're not dealing with patients with lag ophthalmos who don't have good nocturnal coverage of their eyes, and surgical remediation in the majority of patients with this disease really do not require are not required, and except for functional or cosmetic reasons. Moderate to severe TED, which occurs in 30-40% of our patients, of course, we have a huge ascertainment bias at Michigan in that we get referred to us the most severe troubling patients. As I mentioned, glucocorticoids really only elicit measurable responses in 50% of our patients, where there typically is a transient reduction in inflammation. They don't touch proptosis or diplopia reliably, and they're not disease modifying. We and others got on the rituximab bandwagon 15, 18 years ago, and really the results of those studies is inconclusive. We rarely use external beam radiotherapy. Tocilizumab, which is an IL-6 receptor antagonist, is now under study mainly in Barcelona, Spain. And then surgical procedures, as I mentioned, are performed in stages, and about 9.7% worldwide have important untoward consequences of their their surgeries. So surgery is not a panacea. Importantly, there were no therapies registered by the US FDA for TED until January of 2020. So all of the studies that I've shown you in vitro led to a couple of clinical trials. The first reported in 2017, the second in 2020, multi-site. We took the lead at Michigan in both. I mentioned teprotumumab being developed by Roche for cancer, didn't work in cancer, repurposed IgG1, and it's not only a tyrosine kinase inhibitor, it's a beta-arrestin agonist. And I don't have time to go into bias signaling this afternoon, but suffice it to say that the real magic of this drug may be less a function of inhibiting tyrosine kinase and more related to activating the beta-arrestins 1 and 2 in what we call a balanced manner, resulting in very distinct changes in patterns of gene expression. So phase 2, 24 weeks, patients were randomized 1-to-1, had to be 18 to 80, freshly developed TED, 9 months or fewer, highly active CAS scores of at least 4 on a 7-point scale, and they had to be within a stone's throw of euthyroidy. They underwent screening and randomization, and this was double masked, so patients received 8 infusions over a 24-week period. That is an infusion every 3 weeks, followed by 48-week follow-up. Primary endpoint for phase 2 was an aggregate response of reduced CAS score of at least 2 points on a 7-point scale and reduction of at least 2 millimeters of proptosis in the more severely affected eye, the study eye. Phase 3, simply proptosis reduction greater than 2 millimeters in the study eye. Secondary responses as independent variables, CAS reduction, proptosis reduction, improved quality of life using GoQoL, and diplopia improvement. And what I want to show you is that in both phase 2 and phase 3, the aggregate primary response that is CAS and proptosis improvement. Look at 6-week time point. This is after the patient received a test dose, half of the standard 20 mg per kg body weight dose, and then 3 weeks later, 1 full dose, so 2 doses in toto. By 6 weeks, remember, this is a 24-week adjudication. Within 6 weeks of the first infusion, almost 43% of patients had already reached their primary response, compared to 4.4% in placebo. And by week 24, 69% versus 20% in placebo. Phase 3, same story, only better, 78% versus 7.1%. In terms of proptosis response, similar pattern. Within 24 weeks, 71.4% in the active drug cohort, 20% in the placebo cohort, and phase 3, 82.9% had at least 2 millimeters of proptosis reduction versus 9.5% in the phase 3. Pictures are often fairly persuasive. So the patient on the extreme left was in our placebo group of phase 2. Baseline, week 24, not much change there. The middle patient, baseline, week 24. The right-hand individual, baseline, highly diplopic, shut herself in her house, couldn't work, couldn't read, couldn't drive. Week 24, already back to work, driving, reading. Phase 3, a dramatic change in the facial appearance. Again, I would not have guessed that we were looking at the same individual, except for the small nevus on the right upper lid, which seems to be common to both images. MR showing a dramatic change from baseline in the volume of the inferior and medial recti, baseline compared to 24 weeks. The inflammatory schmutz that we see in the connective tissue, that signature has all but departed at 24 weeks. Phase 4, which was just concluded, these are patients with chronic disease from 2 to 10 years in duration, CAS scores of 0, these individuals, again, received either placebo or active drug, 8 infusions over 24 weeks. Substantial reductions in both the number and the magnitude of proptosis at week 24. So what this drug appears to do by inhibiting the IGF-1 receptor or by activating the beta-arrestin signaling pathways, not only does it put on the brakes in terms of disease progression, but it also seems to be involved in reducing, for instance, water binding capacity of the orbital tissues. We're actually studying a number of metalloproteases and serine proteases that might be induced by IGF-1 receptor inhibition. We showed through the years that teprotumumab or 187 or some of the other IGF-1R inhibitors work in vitro in cell culture. But we got our hands on PBMC's peripheral mononuclear cells from patients in phase 2 at baseline and week 24, and we interrogated the phenotypes of these CD34 positive fibrocytes in the circulation. And what I want to draw your attention to is the dramatic reduction in CD80, which is one of the B7 co-stimulatory molecules we're most interested in because provides the molecular wherewithal for these cells, activating T cells, and a reduction in MHC class II expression. 86 similarly reduced, and PD-L1, which some of you may know as a cell cycle checkpoint, and we now know deeply involved in autoimmunity. In terms of the T cells circulating in those patients, dramatic reduction in both number and expression levels of IL-17A and interferon gamma, two cytokines we believe drive TED. Is the drug safe? In general, it's well tolerated. There have been side effects reported, notably changes in hearing, especially in the aged. Also, glycemic excursions, especially in patients with baseline carbohydrate intolerance or frank diabetes mellitus. We're only now beginning to understand the mechanisms involved, which likely have to do with the IGF-1 pathway in cochlear hair cells, where a hair cell deprived of IGF-1 trophism begins to undergo apoptosis. There's also a eustachian tube component to the dysfunction, which is almost uniformly reversible, especially in young patients. So the conclusion of my talk, TED orbital fibroblasts comprise a heterogeneous cell population, including CD34 positive cells. The TSH receptor and IGF-1 receptor pathways appear to intersect and drive TED. Recognizing these interactions has enabled development of teprotumumab, which is effective in reducing severity and activity both in TED and generally is well tolerated. The recent ATA-ETA guidelines recommend teprotumumab for the treatment of patients with TED, especially those with proptosis and diplopia. And I want to thank you all for a wonderful opportunity to speak to you about something I have a passing interest in.
It was clear, crystal clear.
Could you comment on its efficacy in patients with dermopathy and what might the link be?
Yeah, so.
Oh, can you repeat the question?
Oh, yeah. The drug vis-a-vis dermopathy. There have now been several case reports showing a dramatic melting of those lesions in the literature. So virtually everyone who develops dermopathy has awful TED. So they're getting the drug for TED, but their dermopathy disappears or becomes a curiosity, not severe. The breaking down of the tissues is eradicated. So we think that maybe we need to look harder at the impact of the drug on what goes on in the thyroid gland itself. Many of our studies conducted at the very beginning of the science here utilized thyroid epithelial cells. So many of the same mechanisms are involved in the thyroid gland. And because most patients who underwent participation in the trials or in real life have, as it turns out, either had their thyroids ablated surgically or with radioactive iodine, and they're therefore pretty stable. We don't have a sufficient power to comment on any potential impact on thyroid hormone levels, for instance. Really, the only reason why we excluded patients who weren't euthyroid from the first two trials had to do with our concern that had the drug also corrected the thyroid hormone levels in those patients, some of the therapeutic impact might have been interpreted as being mediated through thyroid effects and not effects on the immunologic underpinnings of TED.
Are you concerned about any potential side effects when you're blocking a IGF-1 efficacy throughout the body?
Definitely. Yeah, it's ubiquitous, as is, for instance, the TSH receptor. Yeah, we're very concerned, and we know that this drug and any other that in any way attenuates IGF-1R function also causes relative insulin resistance because, as many of you know, greater than 90% of insulin receptors in the human body are not holoreceptors. They're half receptors insulin and half receptors IGF-1R. And we know that they collaborate in terms of the binding avidities for their respective ligands. So, yeah, I'm hugely concerned about it, but I'm comforted by at least the initial experience with the drug as suggesting that we may not be in a position of needing constant chronic exposure to the drug. But, the point you raise is absolutely critical, and that's why anyone under 18 years of age doesn't get the drug and shouldn't get the drug. Pregnant women and those who are thinking about getting pregnant within 6 months of treatment are excluded. So, yeah, we're very, very concerned. No, you only get one.
That was not him. That was coming from Dr. Famous. So he gets one.
I'm just teasing.
Also, are patients who have a good response to treatment with teprotumumab, but then they recur. I know that sometimes a second cycle has been advocated, but I think, is there anything that can be done to maintain the benefits of this treatment?
I didn't think that.
Are there any how do you deal with recurrence?
How do we deal with the?
To prevent recurrence.
Yeah, when we designed the trials, we based dosing interval and the actual dose of drug on PK, which was generated during the cancer studies, which preceded our TED therapy studies. We don't know how close we are to optimizing the duration of therapy, the total doses delivered. It may well be that personalized medicine will be really the key to tweaking the drug so that it offers the best possible outcome. we see lots of patients still north, more than 50% of patients have sustained durable responses 18 months after their initial 8 infusions. But we know that there's recrudescence in 30% or so of patients, and we don't know whether our treatment was inadequate or whether the disease has revved up again. But we know this is a chronic, smoldering process. And, we're in early days of optimization. Does that answer it?